Good morning, everyone. Welcome to Stanford Pediatric Grand Rounds. We are now hybrid, so we're happy to have those of you who are joining us there in the conference room and those of you who are joining us on Zoom. We start our pediatric grand rounds with a land acknowledgement so that we can recognize that we sit on borrowed land, on stolen land, excuse me. And our land acknowledgement acknowledges that we recognize that Stanford sits on the ancestral land of the Nwekma Ohlone tribe. This land was and continues to be of great importance to the Ohlone people. And consistent with our values of community and inclusion, we have a responsibility to acknowledge, honor, and make visible the university's relationship to Native people. Today, we'll be presenting Health Equity Rounds Revisited, Successes and Future Work, where I'll be joined by our HEAL team and members of the Neonatal and Developmental Medicine Division. Next week, we have our Lucile Packard Hospital Stanford Pediatric Patient Safety Lecture, where Dr. Sarah Toomey will share with us about connecting the dots on safety and quality, embracing the quadruple aim, excuse me. The following week, we'll be joined by Shelley Miyamoto, who will share about the importance of pediatric-specific studies that use our work and the beta-adrenergic system as a framework. We also want to remind you to register for MIC-POP. This is their 42nd annual conference, and they'll be covering a range of topics, including term-based care for infants with renal, aerodigestive, airway, and palliative care needs. So we encourage you to register. And then our pediatric internship program at Stanford, or PIPS, is now calling for faculty and maternal child health mentors. This program is absolutely amazing and is directed by our own Dr. Allison Guerin. The 6-week summer internship ends with the participants presenting their research in posters and also brings their parents here to Stanford to see these presentations. Additionally, they receive counseling about how to apply to college. And so now we'll move into our presentation, Health Equity Rounds Revisited, Successes and Future Work. We have financial support for our HEAL initiative from Baxter Healthcare with a generous gift, so we thank them for that. So despite the fact that our country first recognized and focused on equity and racism in 2020, this work continues. Racism as a system undergirds other forms of oppression. We've seen its effects during the pandemic in the form of disproportionate deaths in Black and Brown people. We saw and continue to see its effects with the extrajudicial killings of Black and Brown people by police. We've seen an uptick in anti-Asian hate, anti-Semitism, and so much more. And fortunately, our department has brought together the Stanford Pediatrics Advancing Anti-Racism Coalition, which worked over the last 2 years. And it brought us the opportunity to work together as a department to advance equity. Our HEAL initiative is a result of this work.
And many of you may remember that Stanford led the way in calling out the issue of racism in healthcare by holding the Rally for Racial Justice back in June 2020. And this event was led by our pediatrics residents. And we include these images here as a reminder that this work is part of an ongoing journey that we've been working on for the past few years and will continue to engage in to dismantle systems of oppression that disadvantage certain groups over others and that lead to inequitable care and health outcomes. And so we've titled this talk Health Equity Rounds Revisited, but what is health equity? So health equity means that everyone has a fair and just opportunity to be as healthy as possible. So this requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness, a lack of access to good jobs with fair pay, quality education, and housing, safe environments, and healthcare. It's about trying to give each person what they need. Every person deserves the chance to be healthy, but due to a range of social and economic factors, good health can sometimes be hard to achieve or maintain. So let's look at this image to explain these 4 key concepts that lay the foundation for the rest of our session this morning. So consider the giving tree on the slide as the healthcare system. So inequality is unequal access to opportunities. So in the image, the tree or the healthcare system is set up so it's bent to one side, making it impossible for the person on the right to get the apple that they need. With equality, tools and assistance are evenly distributed so that everyone gets the same thing. In the image, the person on the right still can't reach the apple that they need. With equity, each person has customized tools to address inequality and are given the tools that they need. In the image, now each person can reach the apple. But with justice, we're fixing the system to be able to offer equal access to tools and opportunities. So in the image, you see the combination of the 2x4s and the strings actually straighten the tree, and that by providing equal resources, everyone can now get what they need. So with that overview of where we've been and a review of some of these foundational concepts, we'd like to review the learning objectives for our session today. So for this session, we have 3 learning objectives: to describe the current and future state of health equity rounds in the Department of Pediatrics, to utilize the health equity round structure to understand and implement individual and local level improvements that can advance health equity, and to plan our own health equity rounds and subsequent improvement work utilizing available institutional resources.
So today I'm joined by Dr. Allison Guerin, the Senior Director of Education, Diversity, Equity and Inclusion and Justice. She's also the co-director of the HEAL initiative. Our Health Equity Rounds faculty leads are Dr. Rebecca Kameny, a clinical assistant professor in cardiology, and Dr. Amit Singh, a clinical associate professor in pediatric hospital medicine. We're also joined by our neonatal health equity champions, Dr. Shamita Punjabi, a clinical assistant professor, and Dr. Elizabeth Blecharczyk, a clinical associate professor, both in the Division of Neonatal and Developmental Medicine. Health Equity Rounds is part of a broader initiative, the Health Equity Advanced Through Learning Initiative. This multimodal educational initiative was the work of the Spark 1.0 training team. HEAL seminars provide foundational knowledge about DEIJ topics and support reaching our Commission on Justice and Equity goal and our department's goal of continuous learning. This year, we're offering in the Department of Pediatrics the Gender and Microaggressions Seminar, and we'll soon be bringing the HEAL Anti-Racism Seminar to LPCH. Huddle guides are one-page micro trainings, and they're really designed to distill down the most important concepts in the HEAL initiative to staff at LPCH that will roll out later this year. Some folks in our department are familiar with these because they were used as part of our faculty practice incentive. I'll pass it off to Dr. Kameny to start our other parts of our presentation.
Thank you, Dr. Floyd. So what are health equity rounds? Allison has set us up nicely to understand the concept of equity, and hopefully by now many of you have experienced health equity rounds in your practice context. They're meant to be case-based discussions that explore issues of equity in the ways they present in our own practice medical settings. In addition to reviewing the case, we then contextualize with relevant literature and historical context. I'll just speak louder. There we go. Thanks. With relevant literature and historical context to provide some scaffolding to understand the context undergirding the case. We also like to leave folks with evidence-based personal bias mitigation strategies, because the goal of health equity rounds is one, to spark conversation, but also to leave folks with individual practice level changes and ideally to inspire local level systems changes. And so again, what is equity-based, equity-focused quality improvement, and what do we mean by that? Well, quality improvement means that the structures and processes that exist in our systems can either enable or prevent errors. And furthermore, we know that our systems are exquisitely designed to get the results that they achieve. And so if we do improvement work without this equity lens to our work, we can actually exacerbate existing inequalities. I'll give you an example. So if we design a health literacy intervention where we send folks home with pictures of their medications and exactly how much, medication to bring up into the syringe, but it's only translated into English and not into the other languages our patients and parents speak, that can actually perpetuate existing inequities. And so there are many ways that we can partner with you to do health equity rounds in your own practice environment. And so first, we'd like to acknowledge the work of the group at Boston Medical Center, as you can see in the MedEd paper that's highlighted there. They first published this paper and provided a framework for health equity rounds that we utilize in our initial pilots. We then have partnered with many divisions as we've continued to iteratively develop this, and we hope to continue that process with you in the coming academic year. When we partner with you, we have a health equity rounds fact sheet, a scaffolding of slides that can help you begin the process. We'll meet with groups from your division to help pick a case, and we can help you facilitate the actual rounds themselves. So it truly is a partnership. So what we've done so far, again, with credit to the Spark 1.0 training team and Cynthia Wong, we piloted 5 different health equity rounds in academic year 2021. These were done in the Heart Center, in nephrology and rheumatology, in addition to other divisions like pediatric hospitalist medicine that were already doing these health equity rounds. In the previous academic year, Amit and I, in our roles as health equity rounds faculty leads, completed health equity rounds with 15 different divisions. And our future plans are to continue these health equity rounds with many of these divisions, and we're excited to see that many of you have signed up for this as part of your FPO practice incentive. But we also want to expand this beyond the faculty focus that you'll see has been the majority of our participants in the previous academic year. We want more multidisciplinary involvement, and we want to engage with our community partners more. So these are the divisions who completed health equity rounds in 21-22. As you can see, there's a very strong representation from the Department of Peds, which we're so grateful for. And Amit and I both learned so much from each division as we partnered with you. And then we also had some folks outside of the Department of Peds, child psych and general surgery, who also put on health equity rounds. Through this process, several common themes emerged, and really the biggest one was language access, such a glaring need that many of you identified as a barrier. And I'm happy to say that our new CQO, Grace Lee, and Naseem Delivery from the Center for Pediatric and Maternal Value have partnered together with other leaders from LPCH to really address this from a systems level, including understanding the inequities and standardizing our systems for language access. So more to come from the institution on that. We also highlighted the role of social work and case management. I think we all knew how important these teams were, but really through these cases, it was further highlighted how great the needs are and how often underserved our populations are and stretched these resources are. Healthcare access, of course, was also a big theme that came up. This was especially true outside the walls of LPCH. Many of our families live in counties where access to mental health coverage and other things are extraordinarily difficult. And this was a tremendous barrier identified for our families. And finally, parental support. We know as pediatricians that our patient is not the only part that we're treating. We're treating the whole family. And if we're only focused on the patient in front of us and their medical diagnosis, we're missing part of that picture. And we found that things like parental mental health supports and other parental social determinants of health supports were really critical to providing the best care for these patients. Now I'll turn it over to Dr. Singh.
Thanks, Dr. Kameny. So after every one of the divisions were able to complete a health equity rounds, we wanted to evaluate informally how the experience went. And so we sent out a short survey for them to complete right after it was done. And about half of the respondents we had returned were physician faculty, but additionally many others such as nurses, clinic managers, or APP staff were invited to participate in the health equity rounds for that division or department, as well as any trainees in those respective departments and divisions. So in the subsequent slides, we'll review a few of the key points of data that we collected. So the first was about mitigating personal strategies for bias. And so what we were able to see was about 79% of our respondents were able to identify strategies, personal strategies to mitigate implicit bias after participating in the health equity rounds, which I thought was really great. The next thing we were able to see was about identifying systems issues that contribute, which is probably one of the most important things and one of the most important reasons we're doing this, not only to educate, but also to think about what can we do after we talk about that. So 94% of our respondents said they were able to begin to identify systems level changes that they might be able to make. And then lastly, one of the final questions was what they were able to learn and how it would impact their practice. And so the majority agreed that what they learned would make an immediate change in the practice that they provide. Overall, everybody rated it pretty favorably, as you can tell, or as you might imagine. And anecdotally, I'd like to say that I'm really proud to be part of a division who's been doing some form of health equity rounds quarterly for the last few years at least. And I'll say it's been very eye-opening to have these discussions together with my colleagues and brainstorm how we can improve the care that we provide for our patients. Moreover, it's really forced me to think more broadly than just my service week or my service day and ask myself, how can I be a part of a broader system of change? And creating the space to have these discussions forces us to objectively approach them rather than lament or complain about the system that's broken, which is one of the most important things we can take away from one of our health equity round sessions. The next few slides are just some snippets of common statements of common themes that emerged when we asked for free response data, which was in what ways will what you learn in what ways will what you learned in this health equity rounds impact your practice. So as you can see, I won't read them all there for you, but we identified changes in personal practice and behaviors, places to identify opportunities for improvement projects, improve general knowledge, and an overall educational value of the session itself. So this brings us to the next portion of our discussion with you today, which is to say, so what's next? Once we've decided to make health equity rounds discussions a part of our standard practice, what do we do? The intention is that health equity rounds are not academic discussions or education just for education's sake, but rather a catalyst to improve our local systems and larger systems in the healthcare area that we provide. It may seem daunting, but today we're going to highlight how one group here at Stanford took the initiative to address the inequities their patients were experiencing in the intermediate care nursery, and to illustrate how all of us can take the next step towards making a change.
Thank you so much, Dr. Kameny and Dr. Singh, for inviting us to share our work today. This morning, we wanted to share a case from our health equity rounds and how these rounds have been implemented in our division, and then discuss how health equity round sits within a broader curriculum for our residents on their intermediate care and newborn nursery rotations. Before we get started, there was a recent op-ed in the New York Times on diversity training and discussion on the effectiveness of these trainings to really change culture. In short, the evidence is not convincing at this point. The recommendation here from Robert Livingston is to focus on actions and behaviors, and this has been the major theme that has emerged for us as we have done this work. Residents want to know what they can do to make a difference and center equity in their care. When we first did our literature review, there were not actionable steps available to combat these inequities. There was no current data on resident knowledge, comfort with, or application of neonatal health inequities in a clinical setting, and no curriculum existed to support residents in reflecting on and addressing inequities that was action-oriented. So we'd like to start off by sharing this illustrative case presented by one of our fellows, Dr. Faith Myers, that we discussed at our December health equity rounds. One of many cases that has inspired Elizabeth and I to pursue the creation of this resident curriculum. Here we focused on the migrant farmer family experience. In the NICU, we had a 1-week-old male who was transferred to us for hyperkalemia and hyponatremia with initial concern for congenital adrenal hyperplasia. Both parents are migrant farmers and have been in the US for 1 year. Their primary language was a specific indigenous dialect from Mexico called Mixteco Bajo, which is quite different from Spanish, but they did understand and prefer Spanish for interpretive services. They had reluctance to hold the infant, though he was stable on 2 liters of high flow. He was found to have pseudohypoaldosteronism and required extensive teaching and anticipatory guidance given his diagnosis. Some examples included NG tube teaching, multiple medications required at discharge, frequent lab checks and subspecialty visits, and home monitoring. As part of this case, we shared these comments that arose while the team cared for this patient. And if you'd like to read them, I'll take a minute to pause here briefly. We asked our participants to discuss 2 things in breakout rooms. 1, their thoughts on the care team's assessment of the family's ability to care for their infant. And 2, the participants' own reflections on how bias might affect their perceptions of this case. From this discussion arose an important takeaway that although many of us, when caring for families, might make observations and may even have concerns, that we should do our best to stop short of making judgments. Here we provided this perspective on the family's social determinants to illustrate the importance of accounting for possible challenges during discharge preparation. We aim to convey that this doesn't mean the parents themselves would be ill-equipped to care for their child, but rather that the team should think creatively about the circumstances that may impact the care and how to be inclusive in our education and ensure that the family is set up for success in caring for their child after discharge. We included this follow-up slide to illustrate how, on the surface, frequent returns to healthcare raise continued questions regarding the ability to care for the child. In reality, the family returned based on the return precautions they were given and the natural history of the condition he was diagnosed with. While parents declined port placement, there was scant documentation regarding conversations about their concerns. And as a result, on a most recent admission, or readmission rather, a SCAN consult, which is the child abuse consult, was recommended. Providers who had an extensive relationship with the family did not pursue this as they felt it was not necessary.
One of the most important pieces of health equity rounds is to convey actions providers can take to the topics discussed. Here we recommended the following: to be aware of the extreme difficulties facing migrant families and the lack of social support being away from their communities. Given they have challenges at being at the bedside, teams should be very proactive, encouraging kangaroo care. We should frame our statements as observations and avoid making judgments or conclusions, especially during provider handoffs. And to practice doing all of this and more, we can use a health equity check-in tool that we created to allow space for reflection and discussion on how we provide the best equitable care to families. This health equity check-in is used as a part of a broader curriculum we implemented for pediatric interns on their newborn rotations. Before we talk in depth about the check-in tool, we wanted to share a timeline for how this curriculum came about and where health equity rounds fits within it. Inspiration for the curriculum came about 2 years ago, shortly after Shamita arrived at Stanford. We were seeing daily reminders of inequitable and judgmental care, somewhat as illustrated in this case we presented, many surrounding language barriers and implicit bias. Initially, we thought we'd pull together some resources from the literature and 1 or 2 months later, roll it out for residents to use. But as we started to dive in more deeply, we realized we needed to take a more scholarly approach, and there weren't a lot of resources available to use. With the support of our division and Becky Blankenberg, we were able to apply for 2 grants. Christina Konechny, a senior resident, was awarded the Western APPD Pediatric Resident Research Grant to conduct the qualitative portion of our study, and Shamita and I received support from the Picker Gold GME Challenge Grant. This same time, we began to conduct the focus groups with our residents to more fully understand their perspectives. From that and other key stakeholder involvement, we were able to launch our first neonatal health equity rounds in March 2022, and finally pilot the new curriculum in June. We identified 3 key stakeholders in this work. The first is the parent perspective. We wondered if we'd need to do parent focus groups, but this had actually already been done by Dr. Krista Sigurdsson in 2018 here at Stanford. This qualitative study explored disparate care as identified by families in the NICU. 3 types of disparate care were experienced: neglectful care, judgmental care, and systemic barriers, with nearly half of all accounts featuring language barriers that cut across race and ethnic dimensions. The next stakeholders are our residents, and they would share their perspectives in the focus groups. The final stakeholders are our community partners. We've had 3 partners who meet with us monthly to inform both the qualitative research questions and the design of the curriculum. It's been vital to have the perspectives of these community experts who are intimately familiar with the challenges our families face, both in the hospital and after discharge. As we were designing this curriculum, we wanted to best serve our patients and residents and realized that gathering as much data as possible from multiple institutions who see a diverse range of patient populations in the Bay Area would be ideal. Today, we're only sharing our Stanford data and implementation, but this work would not be possible without our entire curriculum development team, which consists of faculty and residents from UCSF Children's Hospital Oakland and Mission Bay San Francisco, Kaiser Oakland, and here at Stanford. We also want to highlight our community partners from Glow Preemies and SisterWeb. All 4 academic institutions have now completed focus groups and are designing similar curricula. In the fall of 2021, we completed our 3 Stanford focus groups. We had 17 total residents participating, and one of the 3 groups identified as underrepresented in medicine. 4 themes emerged. They were that residents spotlight inequities and find it difficult to address them in real time. Particularly, they are lacking action-oriented knowledge. Our residents in many ways are leading the way and have deep knowledge, but are looking for tools to address what they've learned and see. Residents express a high level of moral distress due to an inability to fully address these inequities. They desire protected time for action-oriented education, and they emphasize the importance of faculty knowledge and role modeling. We wanted to highlight this last theme on faculty knowledge and role modeling because we see both health equity rounds and our health equity check-in tool as opportunities to address this theme. Our curriculum is called the Curriculum for Inequities in Newborn Care, or CINC. It includes 5 active components, 2 of which aim to target this last theme about faculty development. In addition to the established HEAL seminars designed by the Office of Diversity, Equity, Inclusion, and Justice, we wanted to create opportunities for faculty to increase their knowledge base and comfort level in role modeling. We've highlighted 2 aspects of our curriculum that do this. One is a daily health equity check-in with residents prior to clinical rounds, and the other is supporting faculty development through engagement in neonatal health equity rounds. Health equity rounds is also an important opportunity for the entire multidisciplinary team. In our division, it was started with significant support from neonatologist Sonia Bonifacio, NICU fellow John Feaster, and our division's health equity task force. It occurs quarterly and is fellow-led with faculty facilitation. Thanks to NICU fellows John Feaster, Sheila Razdan, and Faith Myers, who've all presented thus far. Listed here, you'll see the 3 conferences with their topics and action-oriented takeaways. In addition, we're collecting IRB-approved pre- and post-survey data to iterate and improve the utilities of these discussions.
Our second intervention is this health equity check-in script, which is a central part of our action-oriented toolkit. It is a step-by-step guide allowing faculty to role model vulnerability in reflecting on bias and inequitable care, and ultimately encourages residents to do the same with the goal of them leading the check-in towards the end of their rotations. The check-in occurs immediately before rounds to center equity in our daily work and typically lasts about 5 minutes. This script is a tangible reminder to consider the dynamics, challenges, and biases around communicating with families and assessing barriers to care from all angles. It is meant to guide the discussion and plant the seed for reflection throughout the workday. On the reverse side of the script, a daily action guide, which is based on the HEAL microaggressions training, provides specific examples that the team can use to practice combating implicit bias. For instance, in the case that we presented before, the team could practice perspective taking with that case to understand why the family declined home health care, imagining the emotions and worries that they may have had in receiving care in their crowded living conditions and feeling judged by their housemates. All that said, we really want to emphasize that doing a check-in like this doesn't have to be formalized, official, or a daunting task. Sometimes on rounds, we are only able to address one aspect of this sheet or reflect on one family's care for even 1 to 2 minutes. So having the sheet of paper simply serves as a reminder to integrate a discussion on equity into the patient's care plan and not as an afterthought. In our implementation of CINC, we identified several wins and challenges. Successes have been the opportunity to engage community stakeholders who provide a voice to the interventions and education in the hospital setting. We have also focused on providing action-oriented education that can be used within and outside of the nursery setting, such as tools for language access and self-reflection. Finally, we recently learned that our health equity check-in is one of very few actionable tools available to providers, and other institutions have expressed interest in implementing it, even department-wide. At the same time, our challenges have been in the discrepancy between the number of pre- and post-surveys obtained on health equity rounds, making it difficult to interpret or iterate meaningfully on the conferences. It is also challenging to find a time that works well for providers, nursing, and allied health professionals to attend the conferences, and we know that their attendance would make our discussions much more impactful. And finally, the significant time invested in these endeavors requires buy-in from all members of the patient's care team, which has also been challenging. These struggles are similarly faced department-wide in our efforts to implement health equity rounds across divisions. One final thing that we would like to share is that Elizabeth and I have found so much fulfillment and grown so much in our journey participating in this work. Neither of us knew anything about how to implement any of this when we started, except that we felt it was very necessary and urgent to do something about what we were seeing. The important piece of advice that we'll provide is to start somewhere. and not feel like the outcome has to be perfect or right from the get-go. Small interventions can go a long way. We don't consider ourselves experts by any means and have really learned to become comfortable embracing the challenges and exploring the unknowns together as a team. We want to recognize and thank all of our collaborators for learning together with us as well.
Thank you. So I hope you're all feeling as inspired as I am, hearing from their group and all the amazing work that they've been able to do. They're quite humble, but it's really an incredible undertaking. And so as we move forward together, we really want to emphasize that partnership is essential, and we're all here to partner with you and learn from you. And even just looking around this room, I see many fierce champions for health equity from interpreter services, trainees, faculty, and on up. So I'm inspired sitting in this room, and I hope you are too. Our goal moving forward is that health equity rounds can catalyze conversations, but also small, incremental, but measurable changes. Looking at that first slide with all the headlines and maybe listening to the news as you drive into work or walk into work, it can feel easy to be overwhelmed, but we can do small things to change, and the cumulative effect of that change can be powerful. We hope that we can build momentum through these small changes at the local level that then trickle up to have iterative effects. And I've already mentioned some of the LPCH level changes that are being undertaken. The other thing that we've really noticed with this is that we're developing a community of like-minded individuals, which is helpful both to kind of restore each other's passion, restore our inspiration on days when it feels hard, but also to help our patients in more creative ways. So it's not only our healthcare providers, but our staff, our trainees, all of us being committed to health equity and moving forward together.
Thanks, Rebecca. So now what? Again, we were talking about how can we move this forward? And I think I'm definitely feeling inspired. And when we first learned about the work that our colleagues just presented here today, I was pretty impressed. But it can be a little bit intimidating too, right? And the idea here is that anywhere you start is better than not starting at all. And so we'd like to give you a few ideas or a little bit of a blueprint about how you could get started after completing a health equity rounds. The first idea is really that either through systematic review or by doing a health equity round session, you identify the gaps you're seeing in your local practice. The idea here is that any improvement idea should be homegrown. Those who are living it daily are the ones who are best suited to help foster that change. Next, as you guys have seen from what we're showing you here today and from the presentation, this is by no means the job of one person alone. So gather that team, find a partner and work on it together. Find the right people, both locally, in the system, in your community to help you make that change. And lastly, map out a good plan. Like any good hospitalist, I'd be remiss if I didn't talk about the plan, do, study, act cycle. So this is a basic tenet of getting anything done, really, if you think about it. Although we formalize it in QI, we give it this fancy term. Really, it just gets everybody on the same page. So get a project plan together, put your ideas in writing, and organize yourselves and develop a timeline. And using an A3 framework is also a great starting point. And if you don't know what that means, well, don't worry, because there's plenty of things locally, both here at the hospital and at the university setting that can help you. So a couple of things we wanted to point out today is we have the Center for Pediatric and Maternal Value here at the hospital, which is our quality improvement and process improvement departments. You can find more information about those on the intranet. There's also in the hospital setting, our local improvement teams and our QAPIs, or our quality assurance performance improvement groups. So depending on where you work in the hospital or in the clinics, there are people and structures at the hospital to help you move forward. We also have the PQMS homepage, or the Packard Quality Management Systems homepage, where there's a variety of free templates and process maps. The Stanford Medicine Improvement Training Program, some you might have heard of before, the CELT and RIGHT programs. Both of those actually provide like support for your project. And so they're a structured way for you to apply to be part of a program to get a project done. We just wanted to point out that the CELT applications are due pretty soon, next week. So if there's something you're interested in, check out the website. And lastly, the HEAL team. We are all here to help. Anywhere you're starting, many divisions have done this, many divisions haven't done it at all. Rebecca and I and the rest of the HEAL team are here to help. So don't forget to utilize all the support you have here. You don't have to do it alone. So we'll leave you today with this inspirational quote about individually, we are one drop, but together we are an ocean. We have some acknowledgements that we'd like to go through as well.
So we'd like to thank Baraka and Allison, who have been our inspiration and kind of North Star throughout all of this work, and Amit and Ivani in the HEAL office, who have been great partners with us. We want to thank Elizabeth and Shamita for their excellent work and leadership example for us and the institution. All of the divisions who've already completed health equity rounds and those who've signed up for the coming year, we're grateful for your partnership as well. We also want to thank the leadership in the Center for Pediatric and Maternal Value. Both Terry Blecharczyk and Ben Elkins have been great partners for us as we try to translate the inequities we're seeing into improvement work. And finally, we'd also again like to acknowledge the Spark 1.0 training action team, which helped to identify health equity rounds as a training intervention that we could implement, and the folks are listed there. And so thank you all for your attention and for your continued work with us, and we're happy to entertain any questions.
Thank you all so much for such amazing work. I'm Lisa Chamberlain. Thinking about the community partnership part is so exciting to me. I think that's kind of our next step of how do we, find that key group, maybe in the, near where the migrant farm workers are, and, a parent group or something like this, because I think the more we can create these partnerships, the better. And one of the things, two things I want to say. One, our Office of Child Health Equity is really interested in thinking about and partnering with you on that community partnership component, and thinking about both building new partnerships if we need and leveraging partnerships that we've had for many years. The second thing is, this is a piece of work that is happening across Packard and our department, and then also the School of Medicine and the adult side. And so as we think about community partnerships, I think we need to start thinking about alignment across our entire system, because it's not fair to our community partners if we're all coming at them multiple times from different well-intentioned, heartfelt perspectives. But I think we need to also align a little bit. So I love this work and just want to think about how we value that partnership and do it in a really thoughtful way that strengthens the community partner and doesn't drain them.
Yeah, we completely echo everything you mentioned. We actually found it really challenging at first to get community partnership, and would be excited, and I think for any groups, to be able to partner with community partners that were working with the entire institution. I will say much of our grant funding is going directly to our community partners to value the time they're spending with us each month. The other portion, one other thing that was challenging was we really wanted to try and get a parent or patient advisory group, and we couldn't do that here locally. And so I think developing that institution-wide more robustly, especially our families that do not speak English, to be a part of these groups would be incredibly valuable.
Just to build on that a little bit with the family advisory groups, there are some areas in the hospital that are really fortunate to have strong family advisory groups. In cardiology, we're very fortunate as well. In the Bass Center, they have a very strong group, and I think that's a great place to start. One thing we've started doing is there are some heart center task forces to do improvement work, and we've invited family members to be part of that. So that's one example of partnership. And then also to speak to your comment, Lisa, I think one thing that's been great about this work is that it is kind of grassroots and homegrown. And now's the time to start melding that with some of these broader efforts, as you're suggesting. So I think that's really the next stage of a lot of this work together.
And I'll comment. Lisa, I think what you're saying really makes a lot of sense. And I had bounced around this idea with some colleagues of mine that some of are in this room talking about this idea, because one thing I think COVID showed us is a lot of the misinformation game was really hard to combat. And a lot of people just, unfortunately, for whatever reason, don't trust what we say or don't find us to be the right person to deliver the message. And just as we have this set up for the family advisory councils that Karen Wayman leads, we have a robust set of family members who are paid employees as parent mentors who do this work. And I think there's a lot of work to be done. We could do with some more. And one thing I thought would be neat is if we had that same structure for community partners. So people who touch base with us once a month, maybe they are pastors or they're social activists in the local community, people who that community trusts to be the people who are delivering the messages for us and to be the people who can speak for us. Because sometimes, as we've all seen, patients may open up to a social worker or to a nurse, but not to you as a physician or not to you as the resident or the fellow or whoever. So I think engaging with these people makes a really big effort. It is a big effort, but it makes a big impact. And so I'd love to see how the hospital, the university could kind of create that family advisory council structure, but with community leaders. So just to your point, they can come to us and we can go to them, but it's one touch point, one message across the university setting.
Can you hear me? And I will thank you. And what Amit said, I would add, and somebody who's speaking the same language as they are, right? So that would be ideal too. But anyways, today, I just want to say how grateful I am. I am manager of interpreter services, and about 5-6 years ago, Becky right here was our champion of language access in the provider. And I'm just so grateful today to have Jessica Jones as a byproduct, and all of you. And I am so grateful to have had an opportunity to work with all of you to add to the community and system alignment all of the School of Medicine and entities for Stanford. I really want to bring up the internal system inequities that we may still have that are perpetuating access to language. And so why am I grateful that all of you are advocating for this is because from our seat, we can't do this. It's the interdisciplinary work that we have started to do, and we have a lot to do, that we will see that meaningful difference. And like you say, we start whatever we can, and we have taken a few good steps. And I just can't wait to continue to partner with you. There's a lot to do, and you will be receiving an email from me to get together.
There's a few questions in the chat. Mary Chen says, thank you for the amazing work presented. Language access is a common challenge identified in diverse participation in clinical trials and equitable access to novel therapies. How would access to clinical research and innovation be incorporated into the health equity rounds framework and implementation? And Baraka, I think, is going to take that question.
So I think one of the things where it may be helpful to think about this in the context of health equity rounds is if there were a case in which a family was denied entry to a clinical study based on the fact that their language was not represented. We really like to use health equity rounds as an opportunity to work with teams for problems and cases that they've identified in order to bring to the top what we can do or what might be possible. I think one of the other things that our Spark 1.0 team had hoped for was to be able to start doing health equity rounds in clinical research settings, recognizing that not everyone in our Department of Pediatrics, right, takes care of patients, but many people do touch clinical studies. So we would be really open to the idea of piloting a health equity rounds in a research setting to really see what could be possible, because we recognize that one of the roots of inequities is the fact that we don't have diverse representation in many of our clinical trials. Therefore, it makes it difficult for us to say that our science is always generalizable. And we recognize, especially in the era of precision medicine, how important it is to be able to have diverse representation in our clinical trials. So we'd be happy to partner with you to think about how to make that work, Mary.
Hi, everyone. Thank you so much for that wonderful presentation and for the work you're doing. I have two thoughts. One, wearing my education hat as residency program director, I'm so grateful that you brought in some of our trainees to be research partners in the work that you've done, and that our trainees are getting to learn from the health equity rounds that are happening in so many areas, just to be more aware and have an opportunity to discuss the disparities that they're seeing. I also was struck by the topic of moral distress. And I think that, so bias definitely plays into some of these observations. I also think that we, as providers, feel so limited in how much we can affect the environment outside of these walls, that I almost feel like it's a coping mechanism some people use to sort of shut down to some families. And I wonder if there's some processing that can happen through health equity rounds or other ways to help providers feel like, even if we can't solve all of the systemic barriers that are happening outside of these walls, if we can at least help families know that we are compassionate towards them and we're on their side. We may be discharging patients that don't have all the social services in place we'd like them to, but we want them to feel like we care about them and we're here for them and we're not judging them, I feel like that could go a long way towards that moral distress. So just would love your thoughts on how we can work together to do that as a community.
Thank you so much for that thought and that comment. It's something that Elizabeth and I have been pondering a lot as we have been building this curriculum together. And one of the other themes that came up that we had also put up on the slide was just the time desired for self-reflection and debriefing, which was not as adequate as good as it could have been previously. We have really tried to make an effort to take the time to debrief with our residents after they're finished with the curriculum and finished with the rotation, and really giving them sort of prompts to think about as they're going throughout the rotation in terms of things that they've seen from an equities perspective that were addressed on the rotation, or if they were not addressed, why that happened, and how faculty were able to role model for them. And then especially about the emotions they were feeling when a lot of challenging cases came up. And we have now had multiple iterations of residents kind of share some of their thoughts with us about the cases they've encountered. And I think they found it really helpful to be able to have that protected time, even if it's 5 or 10 minutes at the end of their rotation, just to share some of their thoughts on that. I will also say, like, as we've done focus groups with some of the other institutions, this has been a common theme with them as well. And one of the things that they had brought up was really addressing sort of the psychological safety piece around health equity and the ability or inability to address everything while you're on a 2-week rotation as a resident. And how just acknowledging that and really providing a space to say, like, it's not possible for us to solve everything overnight. And we realize that, especially as a resident, your time is so limited and you have all of this clinical stuff to learn. And you also have to keep in mind, all the logistics and then also the inequities that your patients are facing. And it just feels like a lot. It's a lot to carry as a resident and as a trainee. So we are really trying to keep that in mind as we iterate upon our curriculum as well, to find ways to integrate that psychological safety piece in there too. Yeah.
And I just wanted to highlight, I think, 2 really important points you brought up, that kind of components of moral distress that we're presented with. One is when the systems don't match our own kind of moral compass. And that's obviously a much harder thing to change, that we're all working incrementally to, and hopefully pushing towards there. But the other is when our own actions don't line up with that. And as you said, it can be easy and be a coping mechanism to kind of retreat and things like that. I love their health equity check-in and other tools like this that we as faculty can model, and that the trainees actually sometimes model for us, where we can control our own actions in the day-to-day, even if we can't change the systems in the day-to-day. And so aligning our own actions with our moral compass and providing compassionate care does matter, even if it doesn't, completely change the system. And I think that gets into part of Dr. Mendoza's question that we'll get to next, which is that really health equity, I think, is central to so much of our mission, not only providing quality care, but also when we talk about provider burnout and moral distress, et cetera, that's really central as well. If we all got into medicine to provide excellent care universally. And so when we're able to align that better, I think we all come to work with a different attitude. So I think incorporating that across the board is really a game changer.
There's a question from Dr. Fernando Mendoza in the chat. Since health equity is linked with social determinants of health, and social determinants of health have been linked to quality of health care by the Institute of Medicine, should the health equity and the quality of care always be linked in the same sentence in discussions of health equity? I believe this would make all physicians see equity and quality care more strongly linked. As you said, you can't have quality without equity. And I think Baraka was going to take this one too.
Thank you for that question, Dr. Mendoza. I think we're fortunate that our institution also is starting to view it this way and really link health equity with quality of care. So we're really fortunate to have Grace Lee as our new CQO to help pioneer this work and this marriage of our QI, quality of care, and health equity. We also know, right, the Institute of Medicine now has the quintuple aim that includes health equity as part of our work, in addition to addressing provider burnout. So I agree with you. We can't have quality without equity. And we really want to make sure that as we're working with groups, that we're grounding in equity informed or equity revised quality improvement work so that we don't perpetuate inequities with the things that we do.
Another question in the chat from Edward Leibowitz. To what extent do healthcare inequities result from differences in treatment by practitioners based on practitioner bias versus access inequities that prevent patients from getting to the practitioners in the first place? Edward, I think it's hard to separate one without the other sometimes. You know, when Rebecca and I did the health equity rounds, this came up a lot about people's insurance type or where they live and being how far they have to come or being able to get in or wait lists and things like that. And I think people were really frustrated by not having control over what their clinic looks like, allowing longer time for patients who are non-English speaking, things like that. So I think one begets the other. There is some bias for sure that we are working on daily when we try and do these educational sessions, but access is a bigger issue. And I have a little bit of funded time working with our Office of Patient Experience. I know that that's been a big focus too, is to work on that because the system is really difficult for patients to get in to see the specialists they need to. But I do know that from doing these sessions, our practitioners are ready and waiting to see the patients that they know they need to see. And so we're doing our best to be able to get to those. And, you know, I'm proud to say when I sometimes have to put in an order for a follow-up, I have to pick from a long list of clinics, which at that time seems frustrating because I don't know which one to pick. I just want to get the patient in. But I'm happy to see that Stanford Children's Health, or Stanford Medicine Children's Health, I should say, is expanding its footprint across the Bay to be able to get to those places that we can't. So that's a slow go, but I appreciate the comment.
And just to add to that, that really gets to kind of the central point of health equity rounds, is that the answer is yes to that question, right? And so the goal for each health equity rounds is that folks leave with feeling some degree of empowerment for personal change, because we do our own individual interactions do matter, but we know that's not enough. There also needs to be systems change. So the hope is that it also catalyzes systems change and some of the improvement work that we're talking about.
I think the one thing I would add to that is that we do know that studies show us that practitioner bias can affect health outcomes. And so that, to Rebecca's point, is why we try to focus on both those individual bias mitigation strategies and areas of personal growth, in addition to those system level changes.
Thank you so much for your leadership. Baraka and Allison, for your leadership and Amit, for your leadership of our diversity, equity, and inclusion efforts. And then Amit and Rebecca for your work through these health equity rounds. And Shamita and Elizabeth, you've done just a phenomenal job with this project that you've led. And I guess my question is to you. I've been very impressed by your involvement of parental partners, community partners, residents, fellows, and then this Northern California collaborative that you've really created. And I'm curious if you can speak about going outside the walls of Stanford or even outside of our local community, our very small local community, and working with our Northern California partners, and what you've learned and things that you would share with the rest of the group about how to do that work.
Yeah, thank you for that question. I think that has been one of the most enjoyable and growing aspects for Elizabeth and I, is having this multidisciplinary, multi-regional team of collaborators. And as she had mentioned, we just really felt strongly that we were seeing a really diverse array of patients in the Bay Area, and we really wanted the opportunity to be able to represent all of those patients in the work that we were doing. And so I think it helped a little bit that we had some start of a connection with some of the other institutions to try to reach out to them to start this collaboration. And we really had almost immediate interest from all of them in wanting something similar. They had similar gaps in their education, and their residents wanted a similar curriculum. And they were seeing similar inequities within their patient populations, their neonatal populations. So getting the interest wasn't very hard, actually. Everyone was really interested in working on this. We've now been having monthly curriculum meetings for the last year. And we've had, I would say, like, fairly good attendance at all of them, and a lot of great input from all the different providers. And really have learned something very unique from each of the focus groups that we've been conducting at each of the different sites that are really led by their residents actually, and sort of like grassroots at their own institutions. And so as we have done these meetings over the last year, we have had a lot of opportunity to think about how to iterate upon our own curriculum based on the feedback that we're getting from their residents. We've learned a lot from our community partners who have given us invaluable input into the patient perspective. And one of our curriculum objectives is driven very heavily by input from the curriculum, from the community partners in terms of including empathic and compassionate care in our patient interactions. So for me, those have been some of the big takeaways.
Yeah, it's really added an incredible level of richness to the work that we've been doing for having such varied partners. I would say, our curriculum is just a pilot, but for example, at UCSF Oakland, they brought in a whole set of cases that we can use as teaching tools. And so we're going to share those amongst the 4 institutions. And at Kaiser, they were thinking of making scripts because residents were feeling like they wanted to make sure they're using the right language when they're talking to families and patients. And so, we'll be able to share those scripts. Shamita and I and our residents in our focus groups didn't come up with that, but we're going to really benefit from the work that the other institutions were doing to make this a better curriculum. And then we're actually really excited on the hospitalist listserv, but there have been some questions about tools available for this work. And UCLA has reached out to us, and then another institution on the East Coast to learn more about our health equity check-in tool. So we're excited to partner and to actually get some constructive criticism about our tool. So, and how we can make it better. Because honestly, we were surprised when we stumbled upon such a simple thing, but that we can put it into practice each day and feel like we're doing something to address this and start the conversation.
Thank you so much, everyone, for your engagement today in our health equity rounds. We really appreciate your time. Have a wonderful rest of your day.